everyone. My name is Dr. Ekta Bhavesh Thakkar. I am cardiac physiotherapist and working at UNMICRC Hospital since 2011. Under the continuous physiotherapy education, my today's topic is high frequency oscillatory ventilation. First of all, introduction. During conventional mechanical ventilation, we start with minimal setting to achieve the oxygenation and ventilation. As the lung pathology evolves, we may need to increase ventilation support, that is the pressure and volume, to achieve the adequate oxygenation and ventilation. Increased pressure and volume acting on already compromised lung lead to ventilator-induced lung injury. Mechanism of ventricular-induced lung injury include high airway pressure, that is the barotrauma, large gas volumes, that is the volutrauma, alveolar collapse and re-expansion, atelectrauma, and increased inflammation, it is biotrauma. Injury to the lung may lead to other organ dysfunction. This is the diagram which shows the ventricular-induced lung injury. High frequency ventilation. To prevent the ventricular-induced lung injury, high frequency ventilation is introduced as a lung protective strategy. HFV is a form of ventilation with supraphysiological rate, that is more than 150 breaths per minute, and tidal volume less than the dead space. There are 4 types of HFV. First is high frequency positive pressure ventilation, high frequency jet ventilation, high frequency oscillatory ventilation, high frequency flow interruption. High frequency oscillatory ventilation. HFOV is a type of high frequency ventilation that uses piston pump or vibrating diaphragm operating at a frequency of 180 to 2400 breaths per minute to vibrate the air in and out of the lung. Tidal volume, that is 1 to 3 ml per kg. Both inspiration and expiration are active. Oxygenation and ventilation are decoupled. Principle of HFOV. Silicone balloon valves are inflated to variable pressure to generate continuous descending pressure in the expiratory circuit. There is continuous high bias flow in the circuit. This is very important, maintaining the continuous descending pressure, and interruption of this flow even for a 0.4 second result in a lung de-recruitment. Piston speed and displacement generate the frequency and amplitude and vary the ventilation. This diagram, this shows the valve and this is the oscillating diaphragm. There are different models: Draeger Babylog 8000, SLE 5000, infrasonic infant star. Generally we use SLE 5000. This is the SLE 5000 with its circuit. Advantages of HFOV over the CMV. There is small tidal volume that prevents the alveolar overdistension and volutrauma. Higher mean airway pressure improve the alveolar recruitment and leading to better oxygenation. Small gradient between inspiratory and expiratory pressure prevents the cyclical distension and collapse of the alveoli and hence less atelectrauma. Low peak pressure that reduce the barotrauma. It works on an open lung ventilation strategy. Goal in an open lung ventilation strategy is to keep the alveoli at a safe window, less prone atelectrauma, better gas exchange and less pulmonary vascular resistance. Pressure and volume swings in CMV and HFV. During CMV, there are swings between the zones of injury from inspiration to expiration. During HFOV, the entire cycle operates in the safe window and avoids the injury zones. Here we can see the injury zone and safe window period. Alveoli during CMV and HFV. We can see the diagram of CMV in alveoli in CMV and alveoli in HFV. Mechanism of gas transport. Following mechanism were proposed to explain gas exchange in Hfov, that is bulk flow, pedal loft, Taylor dispersion, augmented molecular diffusion, asymmetrical velocity profiles, and cardiogenic mixing. Now we come to indication for Hfov. Inadequate oxygenation that cannot safely be treated without potentially toxic ventilator setting and thus increase the risk of ventricular induced lung injury, that is failure of CMV. Objectively defined by peak inspiratory pressure that is more than 30 to 35 cm H2O, FiO2 more than 60% or the inability to wean. Mean airway pressure that is more than 15 cm of H2O, peak and expiratory pressure that is more than 10 cm of H2O. Relative indication, it includes ARDS, air leak syndrome, congenital diaphragmatic hernia, alveolar hemorrhage, inadequate alveolar ventilation with respiratory acidosis, acute chest syndrome in a sickle cell disease. Hfov controls and initial settings. First we see the bias flow. It is also called the base flow. It supplies the fresh gas and remove the exhaled gas. In preterm, premature 10 to 15 liter per minute, in near term 10 to 20 liter per minute, small child 15 to 25 liter per minute, in a large child it is 20 to 30 liter per minute. If the bias flow is inadequate, the patient circuit's effective dead space increase. This diminishes the ventilation effect. Second is the frequency. Frequency expressed in hertz. 1 hertz is equal to 60 breaths per minute. In a preterm neonates, it is 10 to 15 hertz. In a term neonate, it is 8 to 10 hertz. In a children, it is 6 to 8 hertz. In adult, it is 5 to 6 hertz. Second is the FiO2. Keep the initial FiO2 is at 100%. As soon as the oxygenation improve, the FiO2 may be reduced to lower value. Inspiratory time kept at 33%, that is an I ratio of 1:2 is used. Mean airway pressure. Mean airway pressure is used to optimize the lung volume and thus the alveolar surface area for a gas exchange. Mean airway pressure recruits the atelectatic alveoli, prevents the alveoli from collapsing. Alveolar atelectasis or overdistension can result in an increased pulmonary vascular resistance. Initial MAP is kept at 2 cm above that of the conventional mechanical ventilation. In case of air leak syndrome, that is 2 cm less than that of the conventional mechanical ventilation. Pressure alarm 2 cm above and 3 cm below desired MAP. Then amplitude, it is the degree of deflection of the piston of the oscillator. This deflection is clinically demonstrated as the wiggle seen in the patient. It determines the tidal volume. Set the delta P to 30 to 35 cm of H2O. Observe for a good wiggle that extend up to pubic symphysis and adjust the delta P accordingly. Adjust the piston control to centralize the piston. Wiggle. In a newborn, adequate amplitude is indicated by wiggle up to pubic symphysis. In adult, it is up to mid-thigh. Oxygenation. Two primary variables that control the oxygenation in Hfov are FiO2 and mean airway pressure. Ensure adequate intravascular volume and cardiac output. Lung perfusion must be matched to ventilation for adequate oxygenation. Adequate circulation is required for a tissue oxygenation. Initiate with FiO2 of 100%, that is 1, and map 2 cm of H2O greater or lesser in a air leak syndrome than that of the conventional mechanical ventilation. Increase MAP by 1 to 2 cm of H2O increments at 30 to 60 minutes of interval to achieve the optimal lung volume. Maintain the MAP and wean the FiO2 until 60%. Optimal lung volume, that is increase in saturation, allowing the FiO2 to be weaned. Now ventilation. Two primary variables that control the ventilation in Hfov are amplitude and frequency. In a conventional mechanical ventilation, that is minute volume is equal to frequency into tidal volume, and in Hfov, minute volume is equal to frequency into very low tidal volume. Changes in the tidal volume delivery have a larger effect on ventilation than changes in a frequency. Frequency has an inverse relationship with CO2 removal in a Hfov. Lower the frequency setting, the larger the volume displacement. Higher the frequency setting, the smaller the volume of displacement. Therefore, lower frequency have a larger volume displacement and improve the CO2 elimination. Greater the amplitude, the greater the CO2 clearance. Lower the frequency, the greater the CO2 clearance, and the lower the frequency setting, the larger the volume displacement. Higher the frequency setting, a smaller the volume displacement. In ventilation, set the delta P to 30 to 35 cm of H2O. Observe for a good wiggle and adjust the delta P accordingly. Adjust the delta P in increments of 3 to 5 cm of H2O to achieve optimal PCO2. If PCO2 fails to fall even after delta P elevation by 10 to 20 cm of H2O, decrease the frequency by 0.5 to 1 Hz. If PCO2 fails to fall even after the frequency reaches 3 Hz, consider increasing inspiratory time towards the 50%. Now monitoring and care. Monitoring, visual assessment, activity, posture, behavioral state, chest wall vibration and symmetry. Then wiggle. Chest wiggle factors should be regularly assessed. Close monitoring will afford early recognition of ET tube displacement, airway obstruction with secretions or a pneumothorax. Then auscultation. Lung, no need to stop the oscillator. Listen for symmetry and intensity of piston sounds. Heart, stop the oscillator and then listen. Then arterial blood gas. 45 to 60 minutes after initiation of Hfov. Then second hourly for a period of 8 hours. Then fourth hourly for a period of 16 hours. 8 to 12th hourly after that. ABC value should be checked within 1 hour after major setting change or as clinically indicated. SpO2 should be monitored continuously. Monitoring of hemodynamic status, that is heart rate, BP and CRT. Then chest X-ray. Within 4 hours of initiation of Hfov, 12th hourly for the next 24 hours, daily for the next 5 days, every second day for the next 8 days, every week thereafter during continuation of Hfov as clinically indicated, that is when lung overinflation is suspected. Look for ET tube placement, rib expansion, air leak syndrome and change in the lung disease. Cerebral ultrasound, one initially in neonates after the onset of treatment, then as needed. Then we come to the care. Good communication and adequate explanation to relatives are required due to unusual appearance of patient receiving on Hfov. Humidification of gases, Then suction technique. The closed suction technique is method of suctioning should be only be performed when absolutely necessary. That two in a line suctioning should be done. The closed suctioning technique allows the passage of suction catheter into the airway without disconnection from the ventilator. Advantage of closed suctioning technique includes ventilator setting can be maintained, especially positive and expiratory pressure, continue the oxygen delivery. Frequent position changes. Prone position is required if patient get desaturated or if has a ARDS. Passive limb physiotherapy given. Now we come to the weaning from Hfov. Wean to conventional ventilation when all the following conditions have been satisfied. Pneumothorax and or pulmonary interstitial emphysema have been resolved if present. MAP has been weaned to the 6 to 12 cm of H2O range. Delta P has been weaned to less than 30 cm of H2O. Arterial blood gases have been stabilized in the following range. That pH is 7.25 to 7.45, PCO2 is 35 to 50, PO2 is 60 to 80. First parameter to reduce during weaning is FiO2. Obtain ABG 15 to 20 minutes after weaning to guide the further management. There are some complications of Hfov, that is irritation, hypotension, pneumothorax, endotracheal tube obstruction due to secretions, intracranial hemorrhage, bronchopulmonary dysplasia and necrotizing tracheobronchitis. These all are the references. Thank you.